So good afternoon, I'm Dr. Batar, one of the co-course directors for the musculoskeletal course for the Phase 1 students. I'm also a primary care sports medicine and family medicine attending here at Stony Brook University Hospital. And so today we are going to be going over the examination of the upper extremity. Initially we're going to start with the shoulder, then make our way down to the elbow, and then down to the hand and wrist. With us here as a volunteer, we have Kingsley Boateng, a second-year EM resident here at Stony Brook. So initially, when you approach the patient with any kind of shoulder issue or problems, you're going to start with the inspection process. And the inspection should always take place with you standing directly in front of the patient, and the patient should be disrobed so you can visualize any kind of deformity or issue going on with the patient. Things that you might be looking for when you are going over the shoulder is any kind of deformity or any kind of ecchymosis, edema, erythema, or different deformities that you might look for, such as turning of the head of the humerus in case they have a shoulder dislocation, any clavicular issues where you see one side downsloping or upsloping, and obviously if any bone is protruding through the skin in case of traumatic fractures and things along those lines. This inspection should be done from the front, as we talked about, and then you should also go behind the patient to completely visualize the back of the shoulder, which would include the spine of the scapula, any kind of winging of the scapula, or other deformities. After you inspect the patient, the next step is usually palpation. Now, whenever you're palpating, you should always palpate the quote-unquote normal and abnormal side. As you're palpating, usually you want to start in the middle at the SC joint, and you can take both thumbs and palpate at the SC joint. Now, I like to kind of go through with both fingers. After I palpate the SC, go across the clavicle like this to assess for any deformities. As you're going across the clavicle, you're then going to reach the AC joint, and you want to palpate at the AC joint, the acromion clavicular joint. This usually will be positive in people that have arthritis. As you do that, and you're finished with the palpation of the anterior aspect, you will go back to the coracoid process and then palpate the back. So palpating here at the coracoid process and then coming across the spine of the scapula, you're going to be palpating for any abnormalities on the side here, as well as through the medial aspect of the scapula, going down. This should cover the palpation of the posterior aspect of the shoulder. So after you've finished palpating the patient for any abnormalities, the next step is usually active and passive range of motion. I prefer to have the patient do active range of motion as opposed to passive initially, so that you can gauge what their pain level is versus what mechanical deficits they may be having. So we're going to start out first by telling the patient different maneuvers to check for forward flexion, abduction, external rotation, internal rotation, as well as any kind of adduction and different maneuvers along those lines. So starting out, one of the first maneuvers we'll ask the patient to perform is, can you please take your arms on your sides and reach out towards the ceiling? So the patient is now abducting, and the normal range of motion is usually 0 to 180 degrees as demonstrated by our volunteer. The next thing we would ask the patient to do is, can you bring your hands forward and again reach for the ceiling? Now he's doing forward flexion, which again goes from 0 to 180 degrees, and his arms are now at the side. Can you please take your hands and place them behind your head? And now the patient is demonstrating for us abduction as well as external rotation. And finally, can you pull both your hands behind your back? And the patient is demonstrating for us internal rotation as well as adduction. And the last maneuver will have the patient keep their elbows to their side and have them externally rotate out their arms. And this is external, and bring them back inside towards their belly will be internal rotation. So external and internal rotation round out all the active range of motion. And again, you want to check this bilaterally to compare the quote-unquote good side to whatever issue is bothering them at that moment. Going forward, as we've already had the patient do active range of motion, If our patient is limited by pain, one of the most important things to do is passive range of motion to gauge how much of that pain is mechanical versus discomfort. So starting out, you essentially perform the same maneuvers. You're going to do the abduction to 180 degrees. You're going to do the forward flexion to 180 degrees. Then you can bring the patient up here and do internal and external rotation at this angle, and also bring them down to 0 and do internal and external rotation at this angle. And that should round out your passive range of motion testing if there is some deficit in the active range of motion testing. If they're perfectly doing the active range of motion testing, you don't need to necessarily even do the passive range of motion testing. Next, we're going to be doing rotator cuff strength. So rotator cuff has 4 muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. It's imperative that you know what the function of each of these muscles is. If you understand the function, then you can actually figure out what you're testing and where the deficit lies. So the supraspinatus is the most commonly injured muscle of the rotator cuff, and this is responsible for abduction. To test this, we're going to have our patient reach up to 90 degrees, and then we're going to have him abduct, since this is an abduction test. Now you can do an internal rotation, which leads to what's quote unquote called an empty can or Job's test, and this is the test where you're checking for supraspinatus strength. Now you're going to have the patient push up against resistance. As this takes place, you will see if the patient has 5 out of 5 strength. And your supraspinatus strength testing is complete. The next test is going to be infraspinatus strength testing. And this is going to check for external rotation, because that's what the infraspinatus does. So again, here, one of the important things is making sure the patient's elbow is tucked in to his side. Because if it comes out like this, then the patient is using his deltoid as well as his infraspinatus to externally rotate. So isolating the patient's elbow against his side, you're going to have him push out, externally rotate to check for infraspinatus strength testing. The infraspinatus and teres minor are commonly connected in most injuries. So there's no other test at this time that we advise to learn for for infraspinatus and teres minor strength testing. If the infraspinatus is damaged, the teres minor will probably also be damaged, or vice versa. And so therefore, external rotation testing is good for both infraspinatus and teres minor. If you want to be specific with the teres minor, you can do the hornblower sign, but we can discuss that later on. Moving on, you have the subscapularis, which is responsible for internal rotation. So subscapularis testing can be done in a multitude of ways. The first one we're going to demonstrate here is the belly press sign, where you tell the patient to take their hand and place it across their stomach. As you place the hand on the stomach, you are now going to have the patient push out either with their elbow or raise forward with their hand towards your resistance. This will tell you if the patient has weakness in the subscapularis. The other way to do this is the lift-off sign. So instead of the belly press sign, you can also do the lift-off sign, where you have the patient reach behind their back and then apply resistance as they try to push out. This is also a great test for subscapularis strength and lets us know if the patient has any kind of weakness. This concludes the rotator cuff strength testing aspect of the exam. Now we're going to move on to some special maneuvers. So now we're going to be going over some special maneuvers that are used for shoulder testing. Initially, we're going to start with impingement syndrome / subacromial bursitis. There are 2 special tests that can help us figure out if the patient is coming in with either of these problems. The first test is something called Hawkins sign, which there's a mnemonic to flap your wings like a hawk. So basically, you bring the patient up here to 90. You kind of provide stability at the elbow joint, and then do this internal rotation, downward traction here. If the patient has pain with this maneuver, then they're positive for impingement syndrome or subacromial bursitis. Moving along, the other maneuver for this is called near sign. So the mnemonic for this could be near the ear. as you internally rotate the patient and then bring their arm up all the way up. This would be positive if the patient had pain with this maneuver. And again, this helps you figure out if they have impingement syndrome or subacromial bursitis. Both these maneuvers are done passively. So the patient is not actually doing anything actively. You're taking the arm and performing both maneuvers. Now, speaking of biceps tendonitis, this would be the next disorder that we can check for. There are two specific maneuvers that we're going to discuss for biceps tendonitis. First, we'll talk about Speed's test. So for Speed's test, you're going to have the patient come out in supination to 90 degrees and abducted. Now, why is the patient in supination? The patient is supinated because that is what the biceps tendon does. That is the function of the biceps, supination. So having the patient in supination at 90 degrees, being abducted, you're going to tell them to push up. And if they have pain in this region where the biceps tendon is located, where you can also palpate as the patient is doing this, then that's a positive test for biceps tendonitis. The other maneuver that can be utilized to check for biceps tendonitis is called Yergason's test. In Yergason's test, you are going to grab the patient in a handshake as their elbows tucked to their side, and you're going to palpate for the biceps tendon. To get a feeling for whether you're at the biceps tendon or not, you can have the patient pronate and supinate, and you should feel the tendon here. As you feel that tendon, now you'll provide resistance as they supinate against resistance. And if they have pain with that, that's a positive Yergason's test, which tells us they have biceps tendonitis. Moving along, to check for arthritis, we spoke earlier about palpating at the AC joint. And so as you palpated at the AC joint here and they have tenderness, then that's AC arthritis. Another maneuver to check for AC arthritis is taking the patient up here at 90 and passively bringing their arm across. As we bring their arm across and they have pain, that's a positive cross-arm adduction test, which will tell us about AC joint arthritis. Now, another special maneuver that we can use is O'Brien's test, and this is checking for any labrum injury in the shoulder. For O'Brien's test, you're going to bring the patient again up to 90 degrees, have them internally rotate, but instead of when you check the supraspinatus by bringing them out to abduction, you're going to have them adduct. And as you do that, provide a downward force and load as they push up against resistance. If this is positive, that tells you that they might have labral pathology ongoing. These special maneuvers don't cover the entire shoulder, but they cover a huge aspect of the shoulder. So with these maneuvers, we conclude our shoulder exam for the Phase 1 MSK course. So now moving on to the elbow exam. The elbow exam is very important for many different disorders that are chronic and acute in nature. Starting out, as with the shoulder joint, you want to do a full inspection of the elbow. So to inspect the elbow, you just kind of have the patient bring their elbow up. So you can take a look here where the olecranon is for any kind of bursitis, swelling, erythema, inflammation. You can also have them face the elbow anteriorly, where you can look here on the lateral side for any deformities, fractures, issues of that nature. And then finally, medially, where you can assess for much of the same. After you've inspected both sides, the normal and quote-unquote abnormal side, you're going to move on to palpation. So palpation can be done in any different order. Ideally, you have a system that works for you. You can start with palpating here at the medial epicondyle, the lateral epicondyle, to see if they have any tenderness. Moving forward, you can palpate at the medial epicondyle to see if they have any tenderness. And then you can palpate at the olecranon to see if they have any tenderness. There's also the radial head, which can easily be palpated, as well as the ulna, which can be palpated. So the bony prominences now have all been palpated at the elbow joint, as well as any kind of bursitis or inflammation that you may see. visibly. And you want to feel for warmth when you're palpating as well in those scenarios. Now you want to check the range of motion for the patient. And this can be done actively or passively. The patient's elbow is stabilized and you fully extend. Extension goes all the way up to 30 degrees at times. Now, bringing the patient back to neutral, you can flex. And this can go all the way up to 130 degrees at times. So, flexion, extension. You can also do a stretch both medially and laterally. And finally, the patient is in supination, but you can pronate and then you can supinate. Pronate and supinate at the elbow joint. So this can go between 0 and 50 degrees. This concludes the range of motion portion of the testing. There are also specialized maneuvers that you can do when it comes to the elbow. One of the most common disorders is medial epicondylitis and lateral epicondylitis. Lateral epicondylitis, which is also referred to as tennis elbow, is when you take the patient's lateral epicondyle, which functions in attaching to the extensors of the wrist. So initially, you're going to palpate at the lateral epicondyle, and most patients with this disorder are going to have tenderness on palpation. To further exacerbate this on exam, you can have the patient extend their wrist back, and as they extend, this pain should increase. You can also apply a load as they're extending to resist the extension, which can further make the pain worse. To check for golfer's elbow, aka medial epicondylitis, you can palpate at the medial epicondyle. Now, most patients will have pain just on palpation, but again, this is the region where the flexors attach of the wrist. So you can have the patient flex their wrist as you're palpating, and this can be done against resistance to see if it makes it worse. Those are two common disorders, as is olecranon bursitis. Olecranon bursitis will be visible upon inspection, as they will have a big swelling over the olecranon fossa. There are also other testing maneuvers that can be done. A lot of young athletes, specifically baseball pitchers, will have UCL tears, ulnar collateral ligament tears, on the medial aspect of the elbow. So in that region, you want to palpate as you provide, and you want to palpate here at the medial aspect, and then stabilize it and provide a traction force that will cause a check of the laxity that may occur here. If there is no endpoint, then the patient may have a UCL tear. This concludes our elbow exam portion of the MSK Phase 1 course. So now we'll be moving on to the hand and wrist, and there are a lot of finer things that we're going to look at within the hand and wrist joints to examine the MSK patient. Initially, as we talked about with the other joints, you want to stand in front of the patient and examine both the normal and abnormal joint. And again, you're going to assess the hand and wrist on both sides, looking at the dorsal and now the palmar aspect. It's very important to refer to it as dorsal and palmar in this, and radial and ulnar, as opposed to medial and lateral. Depending on the patient's orientation, the thumb can be now medial and now lateral. So always understand, radial refers to the thumb side, ulnar to the pinky side, and then you have the palmar and dorsal aspects of the hand and wrist exam. So initially, we always look for any kind of scars, any kind of deformity. Deformity in this area, you might have Boutonniere's deformity, swan neck deformity, different deformities that hint at different types of arthritis, as well as any kind of prior injury. You also want to be looking for erythema. You want to be looking for any kind of flexion, extension injury of the fingers to give you an idea of what may have happened. Moving forward, after that's done, one of the first things to do is to check range of motion. So you can again do this actively or passively. and I usually like to have the patient perform active range of motion before I do passive range of motion to discern between any pain versus actual mechanical discomfort. Starting with extension and flexion. There is also radial deviation and ulnar deviation. This is all occurring at the wrist. With the fingers, you can have the same thing, flexion and extension. Flexion and extension. After you've checked the range of motion, for the hand and wrist, there are many neurological issues that can occur as well. So you want to check for any nerve deficits, and you can do that with sensory by palpating and using 2-point discriminatory testing on both dorsal and palmar aspects, depending on which nerve you're checking for, whether it's ulnar, radial, or median nerve. You also want to check for strength. So to do that with the fingers, you'll have the patient spread the fingers out, interlock your fingers in between, and have them close in. You can also have the patient make an OK sign with the thumb and the index finger and pull. These are all ways to check strength testing and nerve dysfunction. After you perform some of those tests, you can do some specialized maneuvers at the hand and wrist. One of the most common disorders of the wrist is median nerve issues. The median nerve issues usually result in some kind of numbness and tingling sensation going into the fingers coming from the wrist. The two tests for this that are commonly known are Tunnel's. And so Tunnel's is where you palpate over the region of the median nerve to look for discomfort. So for about 10 to 15 seconds, you can use both fingers to kind of go back and forth and palpate in this region. The patient will start to have a reproduction of their symptoms as you do this and be uncomfortable. It's wiser to palpate over a wider region than to stay in one area and palpate over there. So this is Tunnel's sign. The other maneuver is called Phelan's sign. Now Phelan's sign is where you're going to flex at the wrist and hold for 10 to 15 seconds. One of the keys is to make sure their elbow is straight as you do this, because the nerve impingement can come at the elbow. By flexing the elbow, you might be making that worse. So to isolate the wrist, you want to straighten out the patient's arm. This is Phelan's, and you want to hold this motion for a good 10 to 15 seconds minimum. This will also reproduce the patient's symptoms. Moving forward, if you want to check for issues in the first compartment of the wrist, de Quervain's tenosynovitis, you can do this by taking the patient's thumb, placing it inside their fist, closing the fist, and then applying a downward traction. This is all done passively. You are performing the maneuver. As you do this, the patient will have redistribution of their pain. This is known as Finkelstein's test. So that's checking for de Quervain's tenosynovitis. Another thing that you want to be careful with is gamekeeper's thumb. This is a common injury that can occur at the ulnar collateral ligament of the thumb in bicyclists. And so here, you want to perform a stress as you stabilize at the thumb joint. And as you provide this stress, there will be no endpoint, or there will be a tremendous amount of pain. This would indicate at a UCL injury at the thumb. Staying with the thumb, an elderly patient might present with localized pain at the proximal thumb. This will likely be due to carpometacarpal osteoarthritis, CMC-OA. To check for this, you basically need to palpate over the CMC joint in the patient's thumb region and see how much pain or discomfort they may be having. After that, the most commonly fractured bone of the wrist after a fall on an outstretched hand is the scaphoid bone. To assess for the scaphoid and whether there's pain or tenderness, you need to palpate in the anatomical snuff box, which again, going back to the thumb, you're going to localize in this region here. So you will be palpating in the anatomical snuff box If they have tenderness in this region, then the patient has a possible scaphoid injury. Getting specific, the second most commonly injured bone in the thumb is the lunate, in the wrist is the lunate. So the scapholunate ligament can be commonly injured, and to check for that injury, we want to find the scaphoid and the lunate, place our thumb or finger between that, and provide an ulna and radial deviation. If you feel a click as you do that, that's a positive Watson's test and hints at a scapholunate injury. And that's something that should be followed up with hand surgery immediately. This concludes the special testing for the hand and wrist exam for the MSK1 course. Two of the more common injuries are mallet finger or jersey finger. Going into the finger, we have the flexor tendon that comes on the palmar surface, and we have the extensor tendon that rides on the dorsal surface. In jersey finger, which is named if you get your finger caught inside a jersey as the player is running away and it gets pulled, your flexor tendon gets disattached and the finger at the tip goes in extension as such. If a patient presents with distal finger pain and the finger in extension, you want to immediately obtain plain films and splint the patient in flexion as such. Now, mallet finger is an injury to the extensor tendon. In this scenario, the patient is going to present with distal finger pain and the finger in flexion as such. So as the finger is in flexion, you want to not splint the patient in hyperextension. So always observe if the patient has distal finger pain after an injury for hyperflexion or hyperextension, which can help discern between flexor tendon injury versus extensor tendon injury.